So this is Process of Human Diseases 1, Nursing 2533, and it's Unit 8 of the Cardiovascular Disorders. So we're going to start the cardiovascular disorders. We're going to start a discussion with congenital heart diseases. These are things that are there from birth. Actually, probably develop before birth. But nevertheless, it's an abnormality of the construction of the heart. So there's really two primary pathological things. One is blood flowing incorrectly through abnormal pathways. So normally blood flows from the venous side into the right atrium, into the right ventricle, out the right ventricle into the pulmonary arteries, through the lungs, back to the pulmonary veins, to the left atrium through the mitral valve to the left ventricle, out the aorta, and back to the body. That's normal pathway. That's the normal pathway for an adult. It's not the normal pathway for a fetus. And sometimes fetal pathways persist after birth, and that's results in blood not adequately going through the pulmonary side of the circulation. There can be problems with the great vessels and that kind of thing too. Or the other thing that can happen is there can be obstructions that block or limit blood flow, and these are due to congenital narrowings of different places. So the common place where that happens in development here, you end up with problems and abnormalities in the atrial septum. This is between the left and right atrium. There's also can be problems with the development of the ventricular septum between the left and right ventricles. We can have problems of the outflow tracts where the aorta and the pulmonary arteries have a shunt through them. The trunctus arteriosus. There's normally in embryonic development a ductus arteriosus that joins there, but this closes at birth. The last thing is the development of the valves. Like there can be problems with valve development that can lead to obstruction or inappropriate flow, backflows. So when we look at embryonic heart, the valves form fairly early, by day 55. If there's a problem with that, then these valves may not function properly. But this diagram here is probably the more important one. In the fetal heart, because the lungs are deflated and not used, the child gets its oxygen through the umbilical cord. Blood flows from the inferior vena cava into the right atrium, and there's a hole into the left atrium that allows blood to pass that way instead of normally going here and to the lungs. So this is called the foramen ovale in the atrial septum. In the adult heart, it leaves a scar called the fossa ovale, but it closes and the septum is intact. So blood flows some into the right ventricle, some into the left atrium from the right atrium. From the left atrium, it goes into the left ventricle, out the aorta, into the body. From the right ventricle, it goes out the pulmonary trunk, and instead of, like, some of it goes to the deflated lungs, but it's not very much. Instead, there is a join between the pulmonary trunk here and the aorta there. So blood flows directly into there. And so the pulmonary arterial blood and the aortic blood mix. And it's a way of bypassing the lungs, which aren't used by the fetus or by the embryo, for that matter. Now, once the child is born and breathing, you want all of this blood from the right side of the heart to go into pulmonary circulation. If this foramen ovale stays open, or this shunt here persists, then what happens is you get a mix of deoxygenated blood mixing with the oxygenated blood, and you have less blood going to the lungs getting oxygenated. So that isn't conducive to good health, depending on the severity of it. It's not fatal, but it's not optimal. So congenital heart problems is a very common disorder in children. It's saying 0.8% of all live births. This is an American statistic. There's no reason to think that it's different as a Canadian statistic, or maybe as a worldwide. It probably is a little higher in third world countries due to some of the risk factors. One of the main risk factors is the mother getting red measles, rubella, during the first trimester of pregnancy. Now, that's not very common in Canada because of vaccination. There's very little measles around. Recently, there was a measles outbreak, and this was the big fear of it, that there were people that were pregnant that might get exposed. They weren't quite certain. Another thing is exposure to cardiac teratogens. Now, a teratogen literally means generates monsters. It's a chemical that will cause birth defects, and we'll talk about those more in the next section. But there's various teratogens that can cause this, and the being exposed to that has to happen early, like in the first days of pregnancy. Oftentimes, because the heart develops very early embryologically, as you saw, within 55 days for the valves to be properly formed. Oftentimes people are pregnant and they don't know they're pregnant, and so they can get exposure to various things and not realize that there's a risk because they don't even know they're pregnant. And some of these things also run in families, so there's genetic influences. One of my favorite lines is that often genetics loads the gun and environment pulls the trigger. So one has to think that maybe some teratogen action is some people are more susceptible than others because of genetic influences. So as I said before, there's two primary pathologies, shunts and obstructions. Shunts are abnormal pathways, obstructions are interference with flow. So the first group of these congenital heart diseases that we're going to talk about are called the acyanotic congenital defects. Now, acyanotic, cyanosis is turning blue, but it's because of a lack of proper oxygenation in the blood. Acyanotic, therefore, means that the blood is properly oxygenated. These things tend to be shunts from the left to the right side. So the left-sided blood, which is the oxygenated blood, gets pushed into the right side inappropriately and doesn't leave the body with cyanosis. We're going to see the cyanotic defects in a few minutes, that where it goes the other way, and deoxygenated blood ends up shunting onto the left side, and there are problems where deoxygenated blood gets pumped to the periphery, and cyanosis is the result. So left to right shunting happens, or some sort of obstruction to flow will cause acyanosis, because obstruction for the most part just means narrowing, and we're going to talk about that for a second. So the disorders include the ASD, atrial septal defect, ventricular septal defect, VSD, patent ductus arteriosus, coarctation of the aorta. Coarctation literally just means narrowing and a stricture. So a coarctation of the aorta, so the aorta grows in a narrowed state. Pulmonary and aortic stenosis is the pulmonary and aortic semilunar valves are too narrow, and so they form an obstruction. Atresia is non-forming, so there is no valve there. It's a complete blockage. That can happen on the pulmonary side or the aortic side. So, first one, atrial septal defect. Now, the septal defect really happens at the foramen ovale most often. Because the foramen ovale doesn't close until the baby is born. Sometimes it remains open. Now, what happens here, because the left side pumps is at a higher pressure than the right side, then what happens is the blood flows left to right through that opening. Now, what that means is that the right atrium fills sooner, and there's more preload to the right ventricle. So that means cardiac output from the right side of the heart exceeds that of the left side of the heart. And that will lead to a pulmonary hypertension, because not only is the right ventricle pumping the blood that's returned via the vena cava, but it's also pumping some of the blood that's already made the circuit and is going through it again from the left atrium. So there's more blood in the pulmonary trunk and arteries than there should be, so that leads to pulmonary hypertension. That increases the afterload on the right ventricle. So the right ventricle works harder to overcome the afterload, and that leads to ventricular hypertrophy on the right side. Now, if this pressure goes up enough and this pressure on the left side drops because of a lack of blood coming through, then this shunt can reverse and become right to left. And so there's some sort of a balance. But if you follow the kind of the logic of this, blood coming into here increases the blood going to there, which increases the blood here, so that has to work harder. there's more blood pressure here, and there's more hypertrophy here. Now, ventricular septal defect does the same, and it's very common. Well, it's more common. And it happens in the membranous septum here, where the bundle of His is. Not so much the muscular septum, down by the apex. So there's an opening here. It's a defect in the septum. Now, this is probably got way more force in it, because the left ventricle is so much stronger than the right ventricle that what happens is blood will flow from the left ventricle into the right ventricle. And so there will be a mixture of deoxygenated blood from the right atrium and oxygenated blood from the left ventricle going into the pulmonary trunk, which leads to pulmonary hypertension. And then, similar to what we just spoke about, you'll end up with a right ventricular hypertrophy. And when the right ventricle gets strong enough, it'll be as strong as the left, and it will reverse the shunt, and we can end up with deoxygenated blood pushing into the left ventricle. That's if the right ventricle gets strong enough through hypertrophy. A patent ductus arteriosus, as I said a few minutes ago, the ductus arteriosus is an important thing. Now, normally, fetally, blood flows this way from the pulmonary artery into the aorta. That's because the lungs are deflated and therefore provide an obstruction to blood flow, and pressure builds up. So the pressure on the pulmonary side is higher than the aorta when the lungs are not inflated. When the lungs are inflated, however, the pulmonary artery pressure drops, and when it drops quite a bit below the aortic pressure. So aortic pressure 120 on systole, pulmonary about 30 on systole. So blood will flow through the ductus arteriosus here and shunt from left side to right side here. And it will, because this pressure is so much higher than this, it's more than even the septal defects, it's going to create a really strong pulmonary hypertension that may just overwhelm the right ventricle, and you'll end up with right-sided heart failure because of it. Now, this normally regresses and disappears and becomes a ligament in an adult. And there's obviously going to be variations on this. Sometimes it hasn't closed completely, and that would still be a patent ductus, or it might be wide open, which would be far more serious. When you get just a little bit, what happens is, as you're auscultating the heart and you're listening for the valves, what you get is this systolic murmur, and it's a thrill, it's a vibration, because the blood gets really turbulent through this little narrow opening. And so you get on systole, you will get this thrill sound. It's not and it's separate from the valves closing, so it's a systolic murmur. And nothing else quite sounds like it. Now, coarctation of the aorta. It happens usually in one of two places. In the diagram, this is showing it post ductus arteriosus. It can also happen pre-ductus arteriosus. Generally, if it happens pre, there's more going on. There's other anomalies, and there's far more going on. It's probably more serious. Now, that actually brings up the idea that, generally speaking, a lot of people have more than one congenital defect. The defects just being there during development can lead to the maldevelopment of other parts. So we're talking about pure forms here, whereas your patients may have a combination of these things. Okay, so this coarctation here, this narrowing, this stricture in the aorta, you can imagine is going to cause the huge afterload on the left ventricle. So you will get ventricular hypertrophy here. Really left-sided enlargement of the heart. So even though there's not a shunt here, it's a restriction and it's a heart defect, but it's not leading to cyanosis. There's no mixing of deoxygenated blood into the left-sided, into the systemic circulation. Quite often, valves don't close properly here, or this valve will close too soon, or so you will get these various murmurs, and they tend to happen at systole because of the extra pressure. Now, when we get stenosis and atresia, it really depends on what it is, which side, whether it's the pulmonary side or the aortic side, and it leads to different things. So if you start out with pulmonary atresia, that means that there is no pulmonary valve. So blood gets through the lungs by going through either an opening in the septum or by having a ductus arteriosa. And that's because there is no pulmonary artery. So the only way, I'll go back to this, the only way for blood to get into here, because this is blocked, so this doesn't fill with blood, is to go this way into this system through that here, or for blood to go this way through a septum and get up through here. So it's quite a serious thing. Now, pulmonary stenosis is usually something wrong with the cusps of the valve, and usually it's some sort of effusion or scarring or something like that that makes it more difficult and for blood to enter the pulmonary trunk. When blood's more difficult to enter the pulmonary trunk, there's back pressure, and so that's afterload, and you end up with right ventricular hypertrophy from it. Now, on the aortic side, if you have aortic atresia, you're not going to be treating anybody with aortic atresia because aortic atresia is not compatible with life. No blood to the myocardium or anywhere else, and so it's just not compatible with life. Aortic stenosis is a fairly common thing, and what ends up happening is that the cusps of the valve narrow or somehow fuse, or there's scar tissue, something, and it results in ventricular afterload, a back pressure, and then you get left ventricular hypertrophy. So think of the stenosis as forming ventricular hypertrophy on the same side. All of these things do not involve bringing deoxygenated blood to systemic circulation. So therefore they are acyanotic. The cyanotic defects go the other way. There's right to left shunting of blood, and you end up with a cyanosis. So the two cyanotic ones that we're going to talk about are the tetralogy of Fellow and transposition of the great arteries. So we'll start with the tetralogy. Tetra means four. So there are four defining features, and it was probably first described by Dr. Fellow. So follow them here in the diagram. So the first thing is this idea there's a ventricular septal defect. So this is a shunt between the left and right ventricles. Now, that could go either way depending on the pressures. Normally, we talk about it as being left to right, at least at first. Now, the second fundamental defect in the construction of the heart is that you'll see here that the aorta is positioned too far to the right, so that the aorta becomes part of the septum above this septal defect. This is probably what's happened first, is that the aorta forms and doesn't allow the septum to form in this place, and therefore leaving this defect. This also then pushes on the pulmonary side, and you get this pulmonary stenosis here. So there's a narrowing of the opening into the pulmonary trunk, and back pressure here. It's more difficult to push up the pulmonary trunk. And then the last thing is you get right ventricular hypertrophy because of it. So what happens here is blood will flow this way, right? And then this will cause hypertrophy. So now blood will flow here and out. So there's a mixture of deoxygenated blood mixing with the oxygenated blood going through the aorta, and therefore this is a cyanotic problem. Now, you can imagine that there are various degrees. If this is a huge septal defect, it may not be compatible with life. If it's a smaller one, then, things will not be good, but at least blood is flowing through both circuits. Now, this one is a little bit more complicated to understand, but it's a transposition of the great arteries. So when the fetus is developing, the aorta and the arch of the aorta comes off of the right ventricle, and the pulmonary trunk, the pulmonary artery, comes off the left, which is completely backwards. What this means in a neonate, in somebody who's breathing, is that blood flow on the right side is a closed loop, and blood flow on the left side is a closed loop. And the two loops don't communicate with each other, because the left ventricle would go out the pulmonary artery to the lungs, back from the lungs through the pulmonary veins to the left atrium, and back to the left ventricle. So there's one loop, vena cava, right atrium, right ventricle, aorta, back to the veins, vena cava. And so there would be the other loop. this is not compatible with life. Now, unless there is another defect that allows the blood to mix, like a patent ductus arteriosa. Now, remember that before birth, having a patent ductus arteriosa is normal and is supposed to be there. Having a foramen ovale is normal and is supposed to be there. So these babies go full term. They because the two circuits are communicating to each other. So in a newborn, as long as these circuits stay communicating, then there is life. They treat these newborns with prostaglandin E, PGE, and that helps keep this ductus arteriosa open until they can get the baby in for surgery and reconnect these blood vessels correctly. Probably a generation ago, these babies didn't survive. More so now. Now, this figure is just to remind you of the anatomy of the heart. I've talked about it enough, but vena cava, right atrium, through the tricuspid valve, left or right ventricle, the chordae tendineae, papillary muscles, out through the pulmonary valve, semilunar valve, pulmonary trunk, pulmonary arteries, to lungs, back through the pulmonary veins, oxygenated blood, to the left atrium, through the mitral valve, into the right ventricle, chordae tendineae, papillary muscles, aortic semilunar valve, arch of the aorta, and the branches off the aorta. Okay, so now we're going to talk about coronary heart disease. Very, very common. I'm sure that you've all seen it already in your practicums. It's characterized by insufficient delivery of oxygen to the myocardium, to the muscle of the heart. Usually it's due to an atherosclerotic artery in the coronary arteries, in circumflex or the anterior intervertebral, posterior intervertebral, marginal, one of those coronary arteries. Now, it doesn't always have to be atherosclerosis to do it, that does it, but that's by far the most common thing. So what happens when you have coronary heart disease? You get pain, angina pectoris. It can get to the point where if the flow is disrupted badly enough, you can get an infarct. So it's myocardial infarction, MI, heart attack. You end up with dysrhythmias because the heart muscle is unable to contract, especially in certain areas, and so you can get dysrhythmia. The heart can lose its ability to pump to overcome the afterload, and that's heart failure. Heart failure is the inability of the heart to actually do its job and pump to overcome the afterload. The heart muscle itself can die, and that would be cardiac death. So all kinds of risk factors, smoking and all of those things, stress, I'm not going to go over again, but there's all kinds of risk factors to coronary heart disease. The atherosclerosis is the common one, and atherosclerosis causes narrowing of the lumen of the coronary artery, which impedes blood flow. Now, if you remember back to AMP, I talked about flow depends on resistance, so it's inversely proportional to resistance, greater resistance, less flow, and delta P, so that's the pressure, that's the blood pressure itself. So, and resistance is affected by viscosity of the blood, the length of the blood vessel, and the diameter of the blood vessel, with the diameter of the blood vessel being the largest contributor, because it's 1 over the diameter to the 4th power. So when half the lumen is gone, you have 16 times less flow. If 2/3 of the lumen is gone, so that you only have 1/3 left, then you have 81 times less flow. If there's 90% gone, so you only have 10% flow, that's 10 times 10, which is 100, times 10, which is 1,000, times 10, which is 10,000. So you have, so for a 90% blockage, you have 1/10,000th the amount of flow of blood through that area at the same pressure. Now, atherosclerosis is the most common thing, but it can also happen because of thrombus, blood clots. It can happen because of vasospasm, inappropriate contraction and vasoconstriction of the coronary artery, or it can happen because of endothelial cell dysfunction and what that entails as far as clot and platelet formation. Remember, platelets stop clumping together because of endothelial factors. Remove the endothelial factors and platelet plugs will start to form, and they can block the lumen and severely limit the flow and therefore the delivery of oxygen. Now, this slide is in here to talk about the difference between arteriosclerosis and atherosclerosis. It's not necessarily clear. The words sound too much alike, and people mix these up all the time. Arteriosclerosis is hardening of the arteries. What happens in arteriosclerosis is that the pulse pressure gets big. So instead of 120 over 80, it becomes 160 over 50. Because the elasticity of the elastic arteries is what maintains the diastolic blood pressure. The systolic blood pressure is caused by the heart. As in arteriosclerosis, the middle layer, the tunica media of these blood vessels, become calcified, or elastic tissue is replaced by fibrous scar tissue, by collagen fibers, and you can't vasodilate. That's the most common way arteriosclerosis goes. Now, atherosclerosis is the tunica intima more than the tunica media. It happens along the endothelial lining of these arteries, and it produces narrow diameter of the lumen and therefore decreases blood flow. So smooth muscle cells start to proliferate, and there's a collection of fats and fatty plaques that form along the tunica intima. So, since fat is a big part of it, we have to talk about the mechanisms. So, lipids are transported by proteins, because lipids are not water soluble and proteins are. By joining a lipid onto a protein and having a lipoprotein, you can move lipids around the circulatory system. This is normal. Now, there's a couple of different types of lipoproteins. One is called a high-density lipoprotein, HDL. These are the good guys. They transport fats, especially cholesterol, back to the liver. So they are responsible for cleaning things up and keeping things. They do the housekeeping. And the liver reuses the cholesterol. Now, cholesterol is used to make hormones. Cholesterol is used to make the myelin sheaths of nerves. Cholesterol is used to make vitamin D. All kinds of things. Cholesterol is a necessary thing, but we don't want it building up on the tunica intima of our coronary arteries or any place else. So what happens is the coronary artery is injured. The endothelium, the tunica intima, gets injured. It could be from chemical stresses, it could be from inflammation, it could be from stress, could be from a number of things. But in any case, the tunica intima gets damaged, and that endothelium becomes permeable, and white blood cells come to the area, leukocytes come to the area, and an inflammatory response happens. The low-density lipoproteins accumulate, and they occur because of oxidation, which happens at this site of inflammation, and macrophages, which are again attracted to these areas. And these oxidized lipids further damage the endothelium, and they attract more macrophages. So it becomes self-fulfilling, it's self-exacerbating, as it were. So then the macrophages engulf the lipids and release inflammatory mediators and some growth factors, all increasing chemotaxis, attracting more leukocytes, and the growth factors stimulate smooth muscle proliferation. So that now we start to get a hyperplasia of smooth muscle. Excess lipids and the various debris accumulate, and they accumulate just under the tunica intima, and they end up with this fatty core. So basically the tunica intima starts to bulge in, and we call these things plaques. Now, just the fact that they bulge in and restrict the lumen increase the resistance to flow and therefore decrease flow. Now, these plaques can sometimes get quite large, and the lipids in them are not structurally stable. If the cap is thin and there's a large lipid core, the blood flowing past it will put a shear stress on it, and there's a possibility of it breaking off and forming an embolism. And we talked about embolisms in the last section, and this is a very real possibility. So if we look at it, what happens here in the lumen, the endothelium, there's inflammation, there is LDLs, so the endothelial dysfunction, so various toxins, smoking, immune reactions, viruses, all kinds of things that can damage this, start this whole thing going. The macrophages migrate to the area, they come through, so this is that whole diapedesis. On the inside of the tunica intima, smooth muscle cells, precursors, and growth factors, and you end up with these things called foam cells, which are macrophages filled with lipids, because the macrophages are eating the lipids in here. The growth factors cause hyperplasia of the smooth muscle, and they proliferate, and There is, in the connective tissue, you get matrix synthesis from the growth factors, and so you end up with this mess of smooth muscle cells, matrix, inflammatory cells, the various cytokines, white blood cells, etc. And it builds up underneath. And it ends up really bulging like this into the lumen. And you'll notice that the smooth muscle cells almost form this other layer here. So starts out nice and clean. We end up with endothelial injury, some plaque, or some platelets and macrophages, etc. They migrate, they get under the tunica intima, growth factors, lipid, cholesterol, etc., etc., and you end up with this. And what does this lead to? It leads to ischemia. Oxygen supply insufficient to meet the metabolic demands of the tissue. Now, the myocardium is a huge user of ATP, so it needs a lot of oxygen. It needs a high rate of perfusion to the myocardium just to keep up with the metabolic demands of the heart beating. So there's a high cellular demand for oxygen. Now, this is going to vary with the workload of the myocardium. So as you exercise, it's going to go up. If you have sympathetic stress, that increases the contractility and the heart rate by increasing both, which puts more workload on the myocardium. If you have high blood pressure, you have a high afterload, that will put more workload on the myocardium. So ischemia happens when you can't keep up to the metabolic demands. Now, at rest, the perfusion may be enough to keep up, but not enough on any exertion. That's why people with coronary heart disease, it's exacerbated by even mild exercise, just by walking in the mall. It's that little bit of extra demand is enough. Now, the perfusion to the myocardium can be altered by anything that blocks the lumen of the coronary artery feeding that area. So that could be a big atherosclerotic plaque, or some sort of a thrombosis, some sort of a clot, platelet aggregation. Vasospasm can do it, which is hypersensitivity sort of things. Per perfusion rates can do it, and per perfusion pressure, which is really blood pressure through the coronary arteries. But if you think about it, then as you get the ischemia and the myocardium can't produce the pressure, then that's going to exacerbate the perfusion pressure, which then, it ends up feeding on itself. Now, there's also either regulation at the arterial end of the capillary beds, and that may fail and give very real problems. All of these things can lead to ischemia, not just the atherosclerosis. Okay, so anginal pain. What happens here is that increased demand is not able to be met by increased supply. And so there's not enough supply. So what happens is that there's not enough oxygen for aerobic production of ATP. When there's not enough for aerobic ATP, then what will happen? You will have anaerobic ATP, and that comes at a price. That comes at quite a bit of lactic acid and quite a bit of other things going on with a very low supply of ATP. And this will happen and cause pain. Now you'll notice that on the increased demand there is increased heart rate, increased preload, increased afterload, and increased contractility. All of those things are anything that causes increased cardiac output. If you remember, increased cardiac output is increased heart rate times, or cardiac output is heart rate times stroke volume, and stroke volume is determined by preload, afterload, and contractility. So anything that is demanding more cardiac output, like exercise, increases the workload on the myocardium, increases the ATP demands. If there's not enough perfusion pressure, because there's some sort of a blockage, or not enough arterial oxygen content, so not enough blood or not enough oxygen in the blood, then what will happen is there won't be enough, a relative lack of ATP. There won't be enough ATP, and you will get this anaerobic pain. Now, the thing about angina is that it's intermittent ischemia. So it happens when the oxygen demand is greater than the supply. When the oxygen demand is equal to or lower than the supply, then there's no pain. So there's no ischemia, really. So what can happen here is increased demand. You will try and compensate, and you're not able to. And now this can lead to pulmonary congestion. So blood will back up into the lungs, and the lungs will become congested, and you'll end up with a shortness of breath. Oftentimes, you will perceive the lack of being able to deliver oxygen as a shortness of breath, even though you're ventilating enough. You're not getting it into the blood. And so that's what people will say. They'll say that it feels like there's a weight on their chest and they can't get a good enough breath. There's three patterns to angina. There's the typical angina, which is also stable angina. And so this is usually caused by some sort of a stenotic coronary vessel, usually atherosclerosis. And there's a generalized stable decrease in blood flow. And then what sets off the angina is anything that's going to increase cardiac output, any increased demands. So the stimuli that cause the angina usually are something to do with exercise, or something to do with stress, or something to do that will increase cardiac output demand. The thing about typical angina is that when the patient rests and or takes nitroglycerin, the pain goes away. And that's because the rest decreases the demand for cardiac output, and nitroglycerin is a potent vasodilator, so it increases blood flow in the sclerotic artery. The prismatal variant is slightly different. There's atherosclerosis, but somehow it's not related to increased myocardial demand. And now what usually happens here is is there something that's going to trigger a vasospasm. Now, if you remember back in AMP when we talked about hemostasis and tunica intima injury, there's the three things that happen. Number one is vasospasm. Number two is platelet plug formation, and number three is blood clotting. But that vasospasm is an important part of hemostasis, protecting against injury. Now, if those mechanisms become hypersensitized, this lack of flow, this atherosclerosis, can maybe put this on a hair trigger. And so what happens is the precipitating factor is unknown. Somehow you end up with a vasospasm, and that vasospasm then leads to angina. It's not predictable. So it's very scary because of that. Now, the unstable, the crescendo angina happens with something called the acute coronary syndrome. So this is the acute coronary syndrome. This is chest pain that is more severe and lasts a lot longer. That doesn't go away with rest. It doesn't go away with nitroglycerin. It often happens because a plaque has ruptured or a thrombus has developed at the place. So even if the endothelium tears a little bit because of the plaque formation, then those endothelial factors that normally stop blood clotting go away, and you get platelets aggregate and they stick, and they can lead to a thrombus development. This may or may not lead to a complete heart attack, to myocardial infarction. If the occlusion that's caused by this is partial and you still have blood flow past there, then it's going to be angina. It's going to be an unstable angina. If the occlusion is complete, then that is a myocardial infarction. There's no blood flows past this place, right? Because no blood flows past the occlusion, then nitroglycerin doesn't matter. It lasts a long time, longer than 15 minutes. Now, the signs and symptoms most of us are aware of: the chest pain, severe shortness of breath. It feels like somebody's sitting on your chest. Pain radiating to the left arm, left shoulder, the jaw, the back between the shoulder blades. Very typical of this, especially in middle-aged men. And as a middle-aged man, I'm quite aware of that. Now, there's also a silent MI, so it has less severe symptoms. The complaints are fatigue, abdominal discomfort, and this happens a lot in elderly people and in women. There's far more silent MIs in women. Now, when you have an MI, when you have the myocardial infarction, there's ECG changes. And so that's one of the reasons why chest pain, like if I go into the hospital at my age and my demographic, I mean, they're hooking me up to an ECG before you know it, because they want to make sure of this. They'll do blood work to look at cardiac enzymes, and we'll talk about it for a second in a couple of minutes. Now, there's two different types, and you've probably heard this talked about on your placements. There's STEMI, which is the ST segment of the ECG is elevated, and that shows that there's an acute ischemia going on. The non-STEMI, the ECG changes aren't as noticeable. There's no ST elevation, but the patient is symptomatic. They have unstable angina, but no ECG changes. Now, one of the problems with MI is that now you have this severe ischemia in the myocardium, which means that part of the myocardium can't contract. That loss of contractility drops cardiac output because stroke volume goes down. So then there are compensatory responses, and the compensatory responses are really to increase the cardiac output. And you increase the cardiac output by increasing heart rate and increasing stroke volume. You can increase stroke volume by increasing preload, which requires a slow heart rate, so that doesn't happen too well, or by increasing the afterload, or decreasing the afterload rather, which you can't really control that well, and blood pressure is dropping, so you want to increase blood pressure at the same time. So it really is by increasing contractility, making that part of the heart that's working work harder. Unfortunately, in myocardial infarction, the compensatory responses lead to increasing the workload because heart rate increases and contractility increases and blood pressure increases, so there's more afterload. All of this is mediated through the sympathetic nervous system, so these people get very sympathetic about this, and so sweating and all of the signs of increased sympathetic response happen. Pupil dilation, all of that. Unfortunately, this exacerbates the problem. Now, this is looking at the etiology of it, and I'm not going to get into it, but you can follow along the diagram. So a person presents with the symptoms, you come up with a working diagnosis, you try and confirm it with the ECG, you look at the blood to come up, oh, yeah, it's an MI. So this is the signs and symptoms. You think that it's acute coronary syndrome. You look at the ECG to decide whether there's an ST elevation or not. If there is, and there's the biomarkers, then you have a STEMI. If there's none, then you have unstable and no biomarkers, then it's unstable. If no ST and biomarkers, then you have non-STEMI. Now, something that isn't mentioned in these slides, but I'd like to talk about. When there is no ATP, then not only can the heart muscle not contract, but the sodium-potassium pumps stop working. When the sodium-potassium pumps stop working, the sodium that's let in at the trigger of contraction doesn't get pumped out. So sodium builds up within the cells, and that changes the osmotic pressures, and fluid goes into the cell. The cell membrane, without the sodium-potassium pump working, becomes unstable and becomes leakier, and this leads to necrosis. The hydropic filling, the water goes into the cells, and the cells burst. When the cells burst, the contents of the cells are released into the bloodstream. So what's in the heart that isn't normally found in the bloodstream? There's something called myoglobin. The heart stores a lot of oxygen. It's very red. So the pigment, the oxygen storing capability of cardiac muscle is myoglobin. That myoglobin will be released into the extracellular space and be picked up in the blood. Actin, myosin, tropomyosin will all be released into the space, as well as troponin. Now, what's interesting is that the actin, myosin, and tropomyosin are also found in smooth muscle and found in a number of other things. The troponin is only found in cardiac muscle and skeletal muscle. So if you see high troponin levels and high myoglobin levels in the blood, then chances are very good that it's cardiac muscle cells that are undergoing necrosis and that are bursting and releasing their contents into circulation. So those are the biomarkers that we look for. Now it takes some time, so it's hours, and you look for an increase in the biomarkers. You know that it's not skeletal muscle because of the presentation. Okay, so the part of the myocardium that's damaged really is related to where the obstruction is. And it's been mapped. Most arterial obstruction are in the left interventricular part of the artery. So the left coronary artery in the front, the left anterior descending. Fully half of them are that. That artery supplies the anterior wall of the left ventricle, the apex, the anterior 2/3 of the interventricular septum. Now, as you remember from anatomy, the left coronary artery also does the left circumflex, which gives the lateral wall of the left ventricle. That's so 15 to 20% of infarcts are because of an obstruction there. An obstruction in the right coronary artery, 30 to 40% of infarcts, are going to give the posterior wall of the left ventricle because it's the posterior interventricular, and the posterior third of the interventricular septum. Now, you'll notice that all of this is talking about the left side, and it's because the left side is the side that goes into systemic circulation and causes this exacerbation. Right-sided is on the pulmonary side and doesn't seem to cause the same sort of positive feedback exacerbation. So that's why we limit it to the left. Okay, so these are some of the serum markers. The myoglobin appears right away. It's a small molecule. The troponin takes longer. It's hours from the onset to peak. It's, the next day sort of thing. CKMB is another enzyme that they look for, and you'll notice that it peaks at about the same time. So these are the serum markers that you're looking for. Now remember, these are cellular contents that are now found in the extracellular fluid, in the blood, in the serum. So you can follow this chart. Myocardial perfusion is decreased because of obstruction in the coronary arteries. That can either lead to partially ischemic cells or totally ischemic cells. If it's partially ischemic, you'll reach that aerobic limitation, and you'll start to make ATP with anaerobic metabolism, accumulate lactic acid, which then will inhibit some glycolysis, and either way you're going to reduce the amount of ATP that's available, just from the fact that you're only making 2 ATPs. Right, that reduced AMP reduces the sodium-potassium pump membrane integrity. As that happens, the sodium will leak and be inappropriate, which changes the ECG. and causes dysrhythmias. Because remember, this isn't all over the heart. So this is one part of the myocardium that is going to be reaching threshold at a different time than the rest of the myocardium. So you end up with these dysrhythmias. The reduced ATP also reduces contractility, which reduces cardiac output, which is then compensated for by the sympathetic nervous system. So that's going to increase heart rate and cause vasoconstriction, because the heart, the blood that's getting pumped, you want it to move faster, so you vasoconstrict. And so that partially ischemic coronary, acute coronary syndrome will lead to all of this. So heart rate's up, vasoconstriction, changes in blood pressure, dysrhythmias, changes on the ECG. If it's totally ischemic, you get no ATP. You lose contractility, cardiac output decreases, sympathetics increase, the rest of the heart tries to work harder, heart rate goes up, vasoconstriction happens. You get a complete loss of membrane integrity, the cells actually rupture. When the cells rupture, there's no electrical potentials, so that means that the ECG will show that, right? And there will be a release of these biomarkers, myoglobin, LDH, CKMB, troponin. And so between blood work, ECGs, heart rate, blood pressure, you will, the diagnosis can be made. So after the myocardial infarction, the stroke volume has gone down. So baroreceptors are activated because now blood pressure has dropped because stroke volume has gone down, cardiac output's gone down. Sympathetics try and bring it up, which cause vasoconstriction, right? But that's going to increase, so that will increase preload because the venoconstriction will bring blood back to the heart faster. Sympathetics will increase heart rate and contractility, which should increase stroke volume and cardiac output. The ventricular wall will have more tension, so the cardiac muscle will hypertrophy, which will then increase stroke volume and CO, right? As stroke volume goes down, you're going to have less blood get to the kidneys, which then causes renin and angiotensin to release, so then you're going to retain fluid, you're going to enhance preload, which is going to increase stroke volume and cardiac output, and then ventricular wall tension, hypertrophy. And so what ends up happening, if you survive the MI, stroke volume and cardiac output will go up to compensate for the loss of stroke volume over the long term by hypertrophy of the myocardium that is actually still working. So obviously, it then behooves us, if coronary obstruction can lead to all of these problems, then, and they're so common, then there's got to be ways of managing it. So if there's plaque and a thrombus, then thrombolysis is the way to go. Now, that could be natural, or it can be by introducing drugs that are thrombolytic. So that's, if there's a thrombus that's causing the total occlusion, then that's probably a good idea. For the anginas and for these partial occlusions, then percutaneous transluminal coronary angioplasty is is a very common thing. And basically, you put a little balloon up there and inflate it and pull it back and try and physically disrupt the plaque, open up the lumen. Lots of people get lots of success from this, especially with smaller plaques. You can also put a stent in, and that's this wire mesh that holds the lumen open and compresses the plaque in figure C. Or a common thing is coronary bypass surgery. So this is really sewing on a conduit that passes by. It's usually the great saphenous vein. It's grafted in and provides an alternate route. It's kind of like when they put temporary lanes in on the highway to get around a construction site. Same sort of procedure and idea. Okay, so sudden cardiac death could be an MI, could be ventricular fibrillation, but this is death from a cardiac cause within an hour of the onset of symptoms. So these are massive heart attacks. This is unexpected death. You're fine and you drop dead. I've witnessed this myself a couple of times. It's the person starts to sweat, has the sympathetic response, shortness of breath, and then bang, they die. My receptionist's father last winter went out, brushed off the car. They were leaving a dinner party, came back in the house to get his wife. Probably the demand on his heart from going out in the cold and from brushing off the car. He walked back in the foyer of their friend's house, clutched his chest, and was dead by the time he hit the floor. Sudden cardiac death. Now, fibrillation, especially ventricular fibrillation, is a common cause of this. And this is why we're seeing defibrillators all over the place and why people are trained to use them. This is what the point of CPR. To get the fibrillation to stop, if you can do that quickly, then there's a chance that you can save the person. Now, what you're going to see far more often is chronic cardiomyopathies, ischemic cardiomyopathies. So these are any diseases of the myocardium caused by ischemia. They tend to be insidious onset. It's progressive ischemia and progressive myocardial damage. You can imagine that if you have a history of angina or ischemia and you've had a couple of MIs, the remaining tissue that's still intact and not scarred is overworked, and then there's more demand and the ischemia becomes progressive. Right? It's common with age, and it's common with other comorbidities, with other vascular issues, with viral issues, with autoimmune disorders, things like that. A lot of comorbidity happens with it.